to the end. Everybody still has a pulse. Okay. At the end of this session, there's 2 of us that might not. These are not my travel clothes. I somehow got roped into being a human anatomy dummy. And I did not think the shoes through, but you know. So Chris is currently my friend, but in about 30 minutes, he may not be. I might be chasing him with a needle. In 2 days, I might be, but Chris is by trade a chiropractor, and then he decided to join the dark side and be a nurse practitioner with the rest of us. So he's got 31 years of experience as a chiropractor. How many as a nurse practitioner? 9, 10. He works at the Albuquerque Neck and Back Pain Center and loves to treat people who have myofascial pain syndromes and specializes in trigger points. And this is going to be a real treat for us because not only is he going to tell you about it, he's going to show you how to do it. You ready? Oh, wait, give us your fun fact.
My fun fact.
His little wiener dog.
Oh, I have a long-haired wiener dog called Schnitzel.
Schnitzel.
Wiener Schnitzel. That's my fun fact.
I like it.
Okay. Wonderful. Since I am the last person and everybody's leaving because it's the last day on Saturday, my name is Christopher Cecil. Again, I'm a chiropractor and a nurse practitioner, chiropractic orthopedist. Is there? Oh, that's the other room. I specialize in musculoskeletal conditions, whiplash, and injuries, no personal professional stuff. Okay, so what are we going to try to learn today? Very quickly, and I have my clock set because I want to, can you get me? I want to have enough time for demonstration. So very quickly, we're going to try to know what a trigger point is, who has them, where they are in the muscles. It's called the Cinderella theory. We'll talk a little bit about it. Find and identify trigger points, review active and latent trigger points, understand referred pain, talk about wet or dry needling, and you may or may not have heard what dry needling is or trigger point injections are, but we'll talk a bit about it. Procedures of trigger point needling, and then of course the demonstration. Okay, and we're not flipping. Okay, let's try one more. We could talk about objectives all day long if you want.
The Zoom attendees couldn't see the slides, so I was just
sorry.
came in here so that they can see it. But you're saying, JD, if I do it now? On Zoom, can you see it? Okay.
We're good?
And now
Okay.
it's good?
There it is, trigger points. And again, I'm going to try and talk very rapidly here. Hyperirritable spot in a skeletal muscle that's associated with hypersensitive palpable nodule in a taut band. So it's a band of muscles that you palpate or feel. And in that band, you're going to palpate a trigger point or a nodule. And in that nodule, that's where the locus of pain is. And we'll talk about what the pain causes. You can see on the diagram, there's a taut band, active trigger point, and it's really contraction knots within the muscle fibers. If you want to know more about trigger points, the red Bibles are the Travell and Simons trigger point manuals that explain most everything. I could talk about Janet Travell for a long time, but we'll continue. What causes a trigger point? Well, there's a lot of different theories as to exactly what a trigger point is, but a lot of consensus that it's end plate damage at the neuro end plate. And there's an acetylcholine spillover along with other chemicals like bradykinin. There's norepinephrine, there's calcitonin gene related peptides and other types of neuropeptides, which causes the area to contract and cause pain in the local area of that trigger point. Trigger point is active apart from regular muscle fibers, meaning the regular muscle fiber isn't necessarily going to hurt, but the trigger point itself will cause pain at that nodule. And it's a bunching up of the small fibrils around the neuromuscular end plate. And typically there's an ischemia or a lack of blood flow in that area. And that's sort of a recent development in terms of research where they've found on Doppler ultrasound that there is a decreased blood flow to the area, which propagates the cycle of trigger points. Okay, so we're just going to say that a trigger point is caused by abnormal or overuse of a muscle, trauma or injury where the neuron plates are injured, dysfunction of a muscle where a muscle isn't functioning the way it should or contracting the way it should. And a lot of times that's because of joint dysfunction or arthritic problems where, let's say, if you have a muscle attached to a joint and the joint isn't doing what it's supposed to, the muscle has to overwork and you end up with a lot of stress to that muscle or trigger points. I liken it to if you have a door that has WD-40 on the hinges and it's easy to move, you can easily move it with your arm. But if you have rusty hinges and the door is off kilter, you got to pull on that door really hard and often, and you're going to stress your arm muscle. So if you have the hinges are, let's say, joints, and your arm is a muscle, you're going to stress that joint. Stress those muscles. Does this look like any of your patients? Okay, that's why there's so many trigger points, especially in the upper trapezius, which we're going to be doing some injections on the upper trapezius because it's probably the most common muscle with trigger points, but especially with all the computer work and pandemic and working from home and ridiculous workstations that people are putting themselves into at when they're working from home, you're going to see a lot of trigger points. Of course, injury, auto crashes, falls, sports injuries can cause trigger points, as well as, like I said, overwork and overuse. So finding the trigger point, that's probably the most important thing. So you need to actually locate the trigger point in order to treat it, or actually even understand that it's causing a problem. So you're going to palpate the trigger point or feel it, and that's the most important thing. But in order to find the trigger point and palpate it, you want to know, or at least have an idea as to where the trigger point is on the body. It's not necessarily where the pain is. It's often causing the pain that they have, and you want to try and identify the trigger point. So what's the patient's activity or work? If you treat a trigger point or know where a trigger point is, then if they're going to consistently work like this, they're going to consistently have trigger points. So you want to try and figure out what might be causing the trigger points. So we'll talk about palpation. There's really two types of palpation. One is a pincer type of palpation. And if you think about your upper trapezius, if you squeeze the upper trapezius, how about everybody looking at the person in front of you? And the people in the last row, you're not going to be able to do it. But look at everybody's upper trapezius or shoulders. You could see like you could grab their upper trapezius areas and squeeze them. And if you pinch, you could pinch a taut band in a muscle, and that would be a trigger point in there. And sometimes you'll get a referred pain. Then there's flat palpation, such as on the Gluteus Medius and Minimus, which we're going to inject today as well. On that, you're going to be actually pressing in with your thumb, elbow, or another area to try to find the trigger point because it's actually on the pelvis itself. So you're going to do a flat palpation for the Gluteus Medius and Minimus. Okay, there we go. Excuse me. All right, types of trigger points. There's active and latent. You want to try and find active trigger points. Active trigger points are trigger points that refer pain or are causing the patient's symptoms. Latent trigger points are trigger points that are there, but don't necessarily need to be treated. For example, many people have forearm trigger points. So everybody just take your hand and press into your forearm and sort of rub. You'll feel, it sort of hurts a little bit, and you'll feel these little taut bands. You probably have latent trigger points in your forearms because they're overstressed, but they're not necessarily causing referred pain. Now, if you have pain into the wrist or into the elbow or tennis elbow, then you might have an active trigger point. But many people have latent trigger points, but we're looking for active trigger points that refer pain. And the referred pain is typically distal from the trigger point itself. So we're seeing, let's say the infraspinatus refers pain down at the arm. You might actually think they have a disc problem or a neural problem or nerve irritation, but it might actually be trigger point problems due to a shoulder problem. And everybody knows about referred pain from the heart, lungs, kidney, and gallbladder, et cetera. And there's mechanisms of referred pain. So let's talk about the upper trapezius. The upper trapezius refers pain where? Well, let's look at it. You can see the, pardon me, you can see the little X's that it's talking about right there. It's referring pain into the head right there. Typically, you're going to get a referred question mark type of referred pain into the head. Often people with headaches will have upper trapezius trigger points causing their headaches. When patients have headaches, or especially tension headaches or chronic headaches that occur 2 or 3 times a week, often they will have trigger points in their trapezius muscle. It also will cause upper trap pain and shoulder pain itself, along with neck stiffness. And let's talk about the anatomy of the upper trap real fast. Just remember, it attaches to the lateral third of the clavicle. So it actually wraps around and attaches to the skull and attaches to the upper portion of the spinous processes, or the nuchal ligament here. So it actually, as you can see on the picture, it actually sort of comes around the shoulder, and that's where the trigger points develop. That's why you can get a good pincer grip on it. Gluteus medius and minimus actually come from the top of the iliac crest and down to the greater trochanter. The gluteus minimus is on the top of the gluteus medius is on top of the gluteus minimus. And typically when you inject or stick a needle in, you can't tell which one you're in unless you're up at the top of the iliac crest. And they will tend to cause referred pain as well. Their function is actually to abduct the leg, but really the gluteus minimus stabilize the pelvis so your pelvis doesn't drop. So what's the referred pain of the gluteus medius and minimus? Good, I'm doing well here. The referred pain of the gluteus medius minimus is, as we call it, pseudo-sciatica. So you'll have patients that come in, they'll say they have sciatic pain, or they have leg pain, or they have a nerve, pinched nerve, etc. Often they will have a hip problem causing pain down the leg. So you want to check this first before you order, or at least try to order an MRI these days, or try to get approval. So they often will have buttock pain, sacroiliac joint type pain. They'll have lateral thigh pain or posterior leg pain. It may or may not have a little tingling to it, so that can throw you off. Sometimes it's usually an aching type pain down their leg. And if you palpate or push into those trigger points in the gluteus medius and minimus with that flat palpation that we talked about, often it can refer that pain, or at least start to cause that pain that they experience. Now, you always want to ask the patient, is that the pain you're experiencing? Is it what you typically feel? Because often they'll just say, oh yeah, that hurts. Ask them if it's going to the areas that cause their pain. One last thing, a lot of trochanteric bursitis is misdiagnosed, and bursal injections are given when really they have a lot of trigger points in the gluteus medius and minimus, and the pain will extend into the greater trochanter because that's the attachment. Before you send out for cortisone injections, check your gluteus medius and minimus. Trigger point injections may be a much better option than actually cortisone into the bursa itself. So we'll talk about dry needling versus wet needling. Why would you do wet needling over dry needling? Well, wet needling, I'll say, is a little more comfortable only towards the end, because you are injecting lidocaine, and that is going to deaden their discomfort. The dry needling is a little more comfortable because the needle's a little bit smaller, but you are not injecting lidocaine. You do definitely get reimbursed more for wet needling, we'll call it, or injections. The ability to move and guide the needle, I find it's easier to move a hypodermic needle than a acupuncture type needle. It seems to bend more, it's harder to move, especially on tough trigger points. And patients perceive it's more therapeutic when you're using a hypodermic needle as opposed to an acupuncture needle. I don't know what that is, but patients, when you're injecting something, they think it's more therapeutic, and believe it or not, sometimes they actually respond better. But dry needling definitely takes less time. So if you're in a crunch, dry needling, you can just whip that out and do some dry needling very quickly. You don't have to fill up a syringe or do anything that increases the time. So what I use is lidocaine. I use 1% lidocaine because it's easier to get. Often docs will use 0.5% lidocaine. I use a 27 gauge needle in the upper trapezius area, and I use a 2-inch spinal needle for the gluteus medius minimus, and sometimes that's enough depending upon the girth of the patient, because often those patients are pretty large. So you're gonna have to gauge your patients to see who might be a candidate for this. You don't wanna get a caulking gun out to get their gluteus medius and minimus. All right, so I use a 25 or 27 gauge needle in the glutes, almost always a 27 gauge needle in the upper trapezius area. And I usually use a 3 milliliter syringe. It doesn't take a lot of lidocaine when you're injecting. Now, let me just say this, the key to trigger point injecting and needling is getting the needle into the trigger point, getting the needle into the trigger point. Why is that? Because dry needling can be just as effective as wet needling, but it has to be in the trigger point. And you have to hit several spots to be as effective as you can, because often you're going to find a lot of trigger points, if you will, in one little area, as Bob Gerwin from John Hopkins says, it's like a little hornet's nest, and you're going to try and find all those little trigger points in one area. So it's getting the needle in the trigger point, which disrupts the end plate, which likely causes your body to repair that, and it restores the integrity. We don't know exactly how it works, but that's the theory. So you got to get the needle in the trigger point. So what does that mean? You have to find the trigger point to get the needle in the trigger point. It's not about sticking the needle into an area that hurts and then just squeezing. Lidocaine. Let me check my time. All right, I think I'm going okay. All right, so dry needling. I typically use an acupuncture needle, a Japanese type acupuncture needle. You can use a 50 millimeter needle, usually in the upper trapezius. I usually use a 60 in the Gluteus Minimus or larger areas. And you're going to move that needle around as well to find the trigger points. A Japanese needle has a tube, and with the tube, you find the trigger point as well as you can. You place the tube on, and then you tap the needle down so it goes into the area that you want. You take the tube out, and then you start moving the needle in and into the trigger point, in and around. Oop, excuse me. All right, procedure. We'll talk about procedures. We're going to locate the trigger point, numero uno, right? Okay. We're going to identify referred pain to try and find out which trigger points we need to inject or needle, because if you find a trigger point, it's not the one that's causing most of their pain, you're not as effective, of course. You're going to palpate the taut band in the muscle. Then you're going to palpate the nodule, which is the trigger point, and you're going to press and see if that causes their pain. And if it does, that's the area you want to inject or needle. Oops, excuse me. And come on, one more. All right, then like I said, prepare to insert the needle. Thought I had one more. All right, so it's a clean technique. You're going to use alcohol and gloves, but it's not a sterile technique. You're going to position the patient. Should it be sitting or lying? Well, a lot of that depends on time. Today, we might just do sitting for the upper trapezius. I'll step back. We'll do sitting for the upper trapezius, and we'll do lying for the gluteus medius. But often I will do lying for most of the trigger point injections or needling, because patients are most comfortable that way. And if they feel like they're going to pass out because they're afraid of needles, they're already in a good position, right? Okay, you're going to insert the needle, locate the trigger point, insert the needle, see if it reduplicates the pain. If it reduplicates the pain, you're probably in the trigger point. If you get a local twitch response or the muscle twitches, you're probably in the trigger point. You don't necessarily have to get that, but that certainly is feedback to you that you are in the trigger point. So getting a twitch is good. Getting a referred pain or a pain into the area is good. If, let's say, in your upper trapezius and it twitches, you can ask them, does that cause a headache? And often they'll say, oh yeah, it goes right to my head. You want to retract them. By the way, reduplication is a good thing. You want to let them know that that discomfort and increased pain is a good thing, because now you're in the trigger point. And so you want to move the needle around. So you're going to retract it, and then you're going to try and re-stick it into that area and find another trigger point that's right in that area. And if you get another twitch response or reduplication of the pain, that is even better if you can. All right. Afterwards, you're going to have the patient lightly stretch, because typically it's a little more effective. So for the upper trapezius, you have them sit on their hand and laterally bend their head. For the gluteus medius minimus, I usually have them put their hand against the wall and lean their hip towards the wall. And tell them, this is very important, the next day they will likely be more sore. The next day, they will likely be more sore. But in 2 days, they will feel a lot better. That's typical, not always. Now, why do you got to tell them that? Because the next day they might hate you and call your office, okay? So you tell them they might be sore the next day, so they're not calling your office saying, I'm worse, what happened? So I think it's time for a demonstration. We have a couple more things to talk about, but. What's that? 22 minutes, okay. Good, we got to get this. Can I borrow my victim? This is Shauna, she is ready. Well, let's see if we could do it. Oh, if you could take it off, that would be great. Thank you. Okay. If you could sit right here, face that way. Good. I'm going to try and go rapidly because.
You can take your time.
Okay. I'll go nice and slow. I'll talk rapidly.
Okay.
And. No, that's my clock telling me I need to start the demonstration. I'm trying to partition my time. All right, it is a clean technique, so I'm just going to alcohol my hands and I'm going to alcohol your area. But great, you might even want to zoom in just a little bit. Okay, first off, let's see what we got. Yeah, there you go. Okay, let's sit up straight. Good. Okay. So this is her upper trapezius. It's going to attach to the lateral third of the clavicle up to the skull and this portion of the neck, the nuchal ligament to the spinous processes. So you're going to see how it comes around like this. I'm going to use a pincer grip. I'm going to grab her upper trapezius. Is that, there you go, great. I'm going to try and find a trigger point. So she has several. She was, if I can say, she was in a car accident not too long ago, so she does have trigger points.
4 weeks ago, head on.
4 weeks ago, okay. And so when I press here, I feel a taut band, and right there, I feel a trigger point. So when I press, does that hurt? Okay. And it hurt here as well? Okay. Does that refer pain anywhere? Does that go anywhere? Where does that go? Tell us. Goes there, okay. Let's press again. Does that go into your head at all?
Yeah.
Okay.
Even higher.
Okay, does it go up here? No, okay. So, okay, sorry. This is probably her toughest trigger point right here. All right, so we're going to inject that. So I'm going to take a posterior approach. I'm going to stick the needle through here. I'm going to have my finger here to know where her muscle is. And we're going to stick the needle in this way. And we're going to inject lidocaine into that area. Then we're going to do dry needling afterwards into a different trigger point, probably very close, but we'll just clean you up first. How's that? Just have to save enough time for glute min, okay? No, you okay, cool. All right, good. All right, I already have my needles set. So I'm going to use, oops, excuse me. Maybe I need my glasses.
Oh, please.
No, to see the needles, excuse me.
They're that small? That's reassuring.
Well, yeah.
Yeah, no. I think nurses are always the worst patients.
Huh. Actually, I must have just, I put 2-inch needles on, but that's okay. We'll just go in just a little bit.
Just a little less than 2 inches is great.
Well, absolutely. We're going to, indeed. Her SCMs and her upper traps will go. Okay, so I actually have a little larger needle, but it's a 27 gauge needle. I have a 3 milliliter syringe, and we're going to find the trigger point again. I'm going to find it with my left hand, okay? And right there, right? Okay. She felt it under her toe. Okay, so I'm feeling a nodule right there and a little referred pain, right? So I'm going to hold my thumb here, and I can feel that's where her trigger point was. I'm going to move my thumb over just a little bit and stick. All right. I'm using a little longer needle. You tell me if you get a little. Okay, so a little refer. So I'll give it a little tiny squeeze. There's a little twitch. I don't know if you can see that. That's called a local twitch response. Unless the patient is really frail, you don't have to worry about the lungs unless you're really, really getting in there. With a 2-inch, maybe a little more, but typically I use a 1 1/4 inch. Well, she doesn't have a ton of local twitch response for some surprise. She's got 2. All right, we got a couple. And what you're doing is you're pulling out and you're finding different spots. And if I do give her any, it's just a little tiny bit and sometimes none at all. All right, good. So just a little bit. Sometimes you'll have a little bit of blood. Typically, I would have a alcohol swab ready in case, but there's nothing there. Okay, now we are going to do some dry needling. So we're going to use an acupuncture needle. This is actually a 60 millimeter because I forgot to bring the 50s.
Is that smaller or bigger?
It's a little longer. Do you want to see what it looks like?
No, I don't. Thank you.
Okay, let me show.
No, you showed them.
See this? Here, look at it. You can barely see it. It looks like your strand of your hair. No, I can't get it in. Well, okay, pretend it was in the, well, let's get a different one. I don't have my glasses on. Okay, so we're going to use a 60 milliliter. We're going to take the little top off so it's easy to put in. Now I'm going to find another trigger point here. We'll see if, okay, just medial to that, right there. Is that tender? Not so much. How about here? How about here? Well, right there, I think will work because there's a little trigger point right there. That doesn't refer as much pain. So I'm going to put my tube here with my needle. I'm going to tap it. Okay, now it's in. Okay. I'm going to take my end and I have my finger here. Now I'm going to guide my needle in. Good.
Now that does not hurt at all.
It doesn't hurt at all. The other one hurt a little more.
Yeah, I have a little referred pain right there.
All right, right there. So she's getting some referred pain. So that's a trigger point. I don't see any local twitch responses.
Oh, my eyes are twitching.
And her eyes are twitching. All right, so I'm pulling it out and putting it in. I don't know if you could see that. And I'm trying to find different trigger points right in the area. And you can move that needle and it's not going to hurt the patient at all once it's in. I mean, that you could barely feel, it just feels like a tug, right?
I don't feel anything.
Okay, good. So she doesn't feel anything. We didn't get a lot of local twitch response. It's actually holding on. So there definitely is a top muscle there. And didn't get a lot of local twitch response. We'll get that off later. But that is all we do for trigger point injections or dry needling. So it can be fairly quick. And if you just do a couple of spots with dry needle, boom, boom, you can get it done. Again, patients don't perceive it as therapeutic, but it's just as effective if you get the needle into the trigger point. Okay, give her a hand. Now we got to do one more person. Now let me move this. Okay, now we're going to do gluteus, medius, and minimus. And we're going to have Adrian come up to be a victim for that. Hold on, let me.
Avert your eyes.
There you go. Let me move all this. Actually, let me put this here. Okay. So I'm going to, we're going to gluteus medius minimus, the muscles in this area. So yeah, we could just lay this on here. Is that okay? Oh, no. Then you use that however you want. Okay, so let's have you lie on your side facing that way. Yeah. So we're going to inject her right gluteus medius and minimus. So this is the greater trochanter, this bumpy thingy here. Okay. And the iliac crest. You're a star. Do you need a pillow?
No, I'm great.
Are you nervous?
No.
You sure?
Yep.
Okay. All right. So this is the bumpy thingy, greater trochanter. The iliac crest is right here. Are you able to see that? Okay. Can you go forward just a little bit with your hips? Yeah, there you go. Good. All right. And then, so we're going to inject into this area. So I'm going to, actually, I'll just keep my gloves on. That's fine. And I'm going to press in here. Can I move this up a little? There you go. We're going to press in here. You tell me if you feel, oh yeah, definitely right into here. Tender. Okay. And tender there. All right. More so here? More here. Oh, more here. Okay. And how about here? Very. Okay. And how about here? No, more here. Now let me ask this. When I press here, does that go anywhere? So into this area. Okay, so it's referring in here. Often you will press, but you actually got to press pretty vigorously into this area because unless, I will say this, if they have hip dysfunction or if they have hip arthritis, they'll almost always have hip gluteus medius minimus trigger points. Or if they have really flat feet, especially on one side or the other, that'll stress this area. So she's got a trigger point in this area. Well, let's find another one. Well, actually, how about here and here? Would that qualify?
Mostly that one.
This one right here. Okay. I just need two. So how about here?
Yeah.
There? No.
Yeah.
Yes.
More forward, yeah.
All right, right there. Okay, so we got two, one here, one here. All right, we're gonna set this up first. Okay, I know you hate this. Sorry about that. But we're gonna pull this down just like this. I won't go too far. Just like that. Is that okay?
Yeah.
Good. So, right there. Okay, so we're gonna start with that. We're gonna use some alcohol. And it is Saturday, so that's what you guys are gonna be drinking as soon as this is done.
Hopefully not hand sanitizer.
Hopefully not hand sanitizer. That's, unless you're desperate. Okay, hold on. We'll just do this now. So just get an alcohol swab. Okay, so we'll just leave this here. Okay, I'm using a 2-inch spinal needle. This is a 27 gauge. We're going to palpate here. Is that the spot? No. Right. Right there. Okay, right there. Okay. Now, when they say it hurts, then I palpate and I really try and find the nodule, which would you say right there? Yeah, right there. You can feel it with your thumb. You got to get in there. You got to really feel it. Now I know it's right there. I'm going to take my needle. I'm going to use my fingers, spread them apart so I don't lose the spot, and I'm going to stick. You're going to tell the patient, stick. Okay. And it wasn't so bad, was it? Now I'm going to move it around. I'm not injecting anything. We're going to see if we can find. No, she doesn't have a lot of twitches. Can you feel it? Yeah, so she feels it. So I'm gonna give it a little bit of lidocaine. You don't need a lot. Sometimes some patients I give them more. Okay. Can you feel that? Not as much. So initially she felt more. And her hip isn't that bad. She has some trigger points, but it's not, she's not somebody that I would do trigger point injections on in the office because she's not having a tremendous amount of problems. Okay, there's a little one. And sometimes you will feel it. I often feel through the needle and I'll feel the trigger points through the needle. So I went a bunch of different areas, I'd say 7 or 8, and the needle moves very easily, and I'm going to take it out and I'm going to recap it. And we're going to use a acupuncture needle now. So we'll use a little alcohol. And we're going to do dry needling now. On a different trigger point. You'd be surprised, patients sometimes will love you in 2 days. All right, so you said a little anterior, so right about here, would you say? Or here?
Yeah, that's good for me.
Okay, so you ask them, you get feedback, and then you feel as much as you can to find a trigger point. It's not really that bad. I would say that's a taut band. Can you feel that? So I would say there's a trigger point right in here. It's not that prominent, but can you feel it? Okay. Okay, it's a little burning. Okay, so I'm going to separate my fingers. I have my Japanese needle with a tube. I'm sticking it right between my fingers, and then I'm going to tap. So the needle's in. Then I'm going to stick the needle in. I'm going to try and reduplicate pain if I can. And by the way, this is not an area you have to worry about. There's an entire pelvis or iliac crest. So it's not like you're going to hit a vital organ. And my needle is actually pretty deep because this, if you see, my needle's in pretty deep. This is a 2-inch needle. I'll go almost all the way down because this area, oh, there you go. I don't know if you feel any.
Oh, I can't feel much of it.
She's not feeling anything, she says. I mean, she's not even feeling pain. So we're moving the needle around. She's not, I feel some gristly fascia, but, by the way, one other thing, if you have a thinner patient and you hit bone, well, when I say thin, I mean real thin. And you hit bone, all right, I didn't mean it that way. If you have a really thin patient and you hit bone, the tip of the needle will be less easy to slide. So then you'll have to move it more or change your needles. So I pull the needle out, and normally I put this into a sharps container. I just don't have one right now. And I'll just make sure everything's okay. There's no bleeding. You can see there's just tiny, tiny little bits. And one thing you want to ask them, obviously, if they're on anticoagulants or if they're on a lot of aspirin, et cetera, because then you want to be prepared for bleeding if there's going to be a lot of bleeding. Then let's have you stand up. Now, what I didn't do is go over upper trap stretch, Shauna, but we're going to go over a gluteus medius minimus stretch with you.
Okay.
So right after, typically you would have them lean against the wall. So I'm going to be the wall. So let's stand right over here. And you're going to put your arm, you're going to put your right hand on me, and you're going to stick your hips towards me. So lean, there you go. Good. And she's going to lean so it stretches this area. Good. There you go. It's going to stretch your gluteus medius minimus. We're going to do the upper trap stretch. I need to take a seat since I didn't do that on her. So right after you do upper trap trigger points, you're going to have them take their right hand, put it underneath their right buttock. If you did the right side, obviously, you're going to have them lean their head this way and lean their body the opposite way. So what you're doing is you're separating the attachments, let's say here and here. So the head's going to be slightly forward, and you're going to have them lean this way because remember, it attaches to the spinous processes, and they're rotating this way. And so now it's going to stretch the upper trapezius. You only have them do it after a trigger point injection, maybe 5-6 seconds, not fast, but 5-6 seconds. Typically at home, they're going to do it a lot longer than that. Okay, you were wonderful. Thank you. Thanks. So, 5 minutes, great. So there's a few more slides I want to go over. How would I get to that? Sweet. Now I'll take my jacket off because now I'll get warm. Well, who needs slides, right? All right. So then without slides, if you can't get to slides, that's okay. I wanted to talk about factors and what you do. There's different things. There's really 4 different ways you can decrease trigger points when patients come into your office with trigger points or pain like trigger points. Number 1 is to press on the muscle. That's why massage therapy works. So when you're pressing on the muscle, you're improving the blood flow and you're improving the neurologic sensation to the trigger point area, which helps reset the end plates. You can stick a needle in it like we just did. You can have them stretch it, which increases blood flow and sort of resets the muscle and the end plate. And then you can move the joint or improve the joint function of that muscle. So like I said, with a door and hinge, if the joint isn't working properly, you can improve that function. That's what I do as a chiropractor, improve joint function. If they have a lot of arthritic change, it's just going to be palliative. If they need a hip replacement, you're never going to totally get rid of their trigger points, but you can do what you can. And then, of course, you're going to look at their posture. You're going to look at their posture. You're going to look at what they do. If they are chronically sitting like this, you're never going to decrease their trigger points, but you can help them with that as long as you do injections or refer them out for some trigger point work. For the Gluteus Medius and Minimus, you can watch their arches or their shoes. If you look at their heels and they're just totally worn out, they're obviously going to have hip issues because of how they're walking. Or if they are walking with a limp, or if they had an issue, they might have a lot of trigger points that are occurring because of a secondary problem that they have. So you want to try and do all that stuff or look at that. So really in my office, we try to decrease trigger points before we stick needles in. We try to stretch the muscle, put pressure on it. We have massage therapists. We try to move the joints, and then if they don't improve, then we stick needles in. Oh, now we actually have slideshow. Great. So I'll get through this really fast because I have 2 more minutes. So it's pretty much what I was just talking about. Light exercise increases blood flow to the muscles. Obviously, you want to encourage patients to do light exercise, not heavy weightlifting exercises that may activate their trigger points, especially in some weightlifters. When they overdo it, they may have chronic trigger points because they're overly weightlifting. Oh, sorry. All right, that's okay. That's okay. Should I tap that? All right, good.
When it shows up. Does it work?
All right, light exercise, stretching. That's one of the stretches I talked about. And then posture, of course, and it doesn't work. That's okay. All right, don't worry about it. So there's lots you can do. I suggest you get the Travel manuals if you're really interested in trigger point injections and trigger point therapy. Is it working? Okay. Oh, go ahead. Click then. All right. I guess that's it. Christopher Cecil, Albuquerque Neck and Back Pain Center. If you have any questions, my office is right near the university, Indian School and University. You can always Google me and find out where my office is. Give me a call or email me. Call my office. I have no problem talking to you about that. So any questions? You have a question?
I do.
Yes.
I do. Okay. So now I'm a little sore
Yes.
and I'm going to hate you tomorrow.
Yeah.
What do you say about like symptomatic relief? Ice,
If
heat,
it's really bad, you could
NSAIDs?
take ibuprofen.
Okay.
Yeah. You won't need narcotics. It won't be that bad.
Oh, I think I might though.
Yeah. Okay. So somebody, no, okay. If it's really bad, you could take ibuprofen, but usually the next day you're going to be sore, or even that day. What's interesting, some patients will feel great right away, and some will definitely be sore. And then just tell them in 2 days, typically you'll feel a lot looser and you'll have less discomfort. By the way, it's when they have headaches, often the headaches will decrease and they'll say, wow, yeah, I have a lot less headaches. Won't a lot of times get rid of them all if they're getting headaches 4 times a week, but their frequency and duration and intensity will tend to decrease as well. Any other questions? I know it's the last session. Is that it? All right, it's hand sanitizer time, guys. All right. Oh, hey, that'd be great. That's perfect. Thank you.